Okay, good afternoon and a very warm welcome to the Oxford Martin School and a warm welcome to the first of this term's seminar series. This is a celebration of 10 years of the Oxford Martin School, and I'll tell you a bit about the seminar series at the end. That means it's 10 years of research here into the global challenges of the 21st century, which is the small remit of the school. Now, demographic changes across the world are clearly one of the biggest of those and intersect with many of the topics which we worry about in this building. So today we have two speakers who will be talking about demographic change and the evolving health challenges. So we have Professor Sarah Harper, who's going to talk about the causes and effects of population change and also the changing profile and age structure and some of the interesting dynamics of that. Now, Sarah is co-director of the Oxford Institute of Population Aging. She's a professor of gerontology here at Oxford, as well as a senior research fellow at Nuffield College. She's also governor of the Pensions Policy Institute. She chairs the UK Government Foresight Review on Aging Societies and the European Aging Index panel for the UN's Economic Commission for Europe and its population unit. And she also serves on the Prime Minister's Council for Science and Technology, and that's just a small selection of the various things she has on her bio. And then we're going to hear from Professor Robyn Norton, who will address the implications of those demographic changes on global health. And Robyn is the co-founder and principal director of the George Institute for Global Health, which has about 500 people working across the world, with headquarters in Oxford and in Australia, in Sydney. Robyn is internationally regarded for her research on causes, prevention and management of injuries, as well as the management of various critical conditions in surgical and intensive care settings. But she also has a long-standing commitment to improving women's health, particularly in resource-poor environments. Now, she is Professor of Global Health and a James Martin Professorial Fellow here at the University, as well as Professor of Public Health at the University of Sydney, and an honorary professor at Peking University. So we are in good hands. What we're going to do is hear first from Sarah, then from Robyn, and then we will have questions afterwards with both of them up here. So if you could hold your Sarah questions until the end, and then we've got plenty of time for a Q&A at the end. So I'll hand over now to Sarah.
Thank you very much, and thank you, Martin School, for inviting me and Robyn to start off the celebratory series. This is very important to the Institute because we actually joined the Institute in May 2005. Back there when James Martin had this fantastic vision that we could have really high-class research addressing the challenges of the 21st century, he approached three directors of three existing research units at the University of Oxford. There was the Institute of Population Aging, there was the Environmental Change Institute, and there was the Institute for Science, Innovation and Society. And so those three existing institutes looking at people, the planet, and science and technology and research that links them together were at the core. And as you know, the school then grew and grew and grew, and I think there are now 35 programs, institutes. So for us, to try and reflect over the 10 years within which we've been within the Oxford Martin School has actually been very rewarding as we sort of looked back. And we've been very lucky. We've had 6 grants between 2005 and 2015 from the Oxford Martin School. So you have made a fundamental difference to our research profile. And I also want to say thank you to the staff of the Martin School, because people often forget there's this huge growing group of people who look after us, and you really have been fantastic. So that's my beginning. What I want to do is talk about the big research questions. What are the research puzzles that we have tried to tackle over the last 10 years? Let's put some kind of context, then a very little bit about the Institute and the way it approaches. But the majority of the talk, I want to take just 3 pieces of research that we've done in different parts of the world and try and show how we have contributed to understanding the global challenge of demographic change. And I know everyone is into impact and making a difference, but to be perfectly honest, when you are a researcher, you're just working away at a little piece of the jigsaw, and you just hope your little puzzle fits in to the bigger picture. So that's what I'm going to try and show tonight. So we work on this. This is age structural change. What we're basically interested in, the fact that through falling fertility and falling mortality, first across the life course, now increasingly late life falling mortality, we have altered the age structure of the globe. And we divide our work really into these three broad regions. I'm going to do on this one. Sorry for people over here, but this one on this side at the top, that's advanced economies. This is the emerging economies, and these are the less developed economies. And for those people who are economists, it fits very well into the World Bank high income, mid-income, and low income. Not exactly, but it's more or less comparable. But this is the way that the UN defines it, and we're going to use UN figures when we do our big maps to show you, and that's why we tend to look at it from that perspective, put those countries together. The really important thing to notice is that if you look at the green, the red, and the blue, you can see in advanced economies growing numbers of green, that's the over 65s, diminishing numbers of blue. You can see the same transition occurring in the emerging economies, a decline in the number of children, a slow increase in the number of older. But when we come down to the bottom section, you can see huge numbers of children still in the least developed economies of the world. These are typically in sub-Saharan Africa, a few in Asia still. But this also this mass of midlife people and a very small group of older people. And this transition is really, really important. Because as these society transition, so we have to look at how does this reconfigure the society, the healthcare systems that we'll hear about later, the political systems, their economies, and there are all sorts of fears about the aging of the population in advanced economies. Here, in emerging economies, what are we going to do about this massive growth in people of working age, particularly young working age? Will this be a youth bulge, or can we convert it into a demographic dividend? Will China actually be able to sustain its economy? Will India be able to educate and provide the institutions that the Indians can drive their economy? And then, when we look at the least developed economies, huge fears about still the very high fertility rates that are there. But I also just very quickly want to show you some other, again, big macro data, and this is a population pyramid. And I think it shows two very important things. We've got women on one side, females on one side, male on the other. I want you to concentrate on the green, which are the advanced economies, on the brown, which are India, the purple, which is sub-Saharan Africa, and then the Far East Asia, typically China, which are the blue. So in 1990, classic pyramid still in the world. We had larger numbers of people at the bottom, diminishing as we went higher, death across the life course. But if you look at what is happening, let's look at what's happening at the bottom. When we go to 2000, already we see a reduction in Chinese births. We see an increase in Indian, but also a growing increase in sub-Saharan births. But really importantly, of course, is what has happened already in the advanced economies. We have lost our pyramid shape, and we're much more like a skyscraper. 2020, again, diminishing births in Asia, but growing number of births at the bottom in Africa. And finally, by 2050, this has happened. So the population pyramid, which was this shape, has actually now become, this U shape here. And that's really, really important. So what we've seen is large numbers of births going away from China and India. Asia is no longer driving our population from a birth point of view. It's actually Africa that will be providing the babies and therefore the young people of the world. But here we have the filling out of the population pyramid. So people who say massive overpopulation, we're going to go roughly between the beginning of the graph that I showed you to this one, from about 7 billion to about 10 billion. But about 3 billion of that is actually going to be the filling out. People are not going to die across the life course. So if you like, people are not demographically dying on time. And that's one reason why our population is growing. So for the first time in the 21st century, longevity is going to be driving population growth as well as fertility. And I think that's a really important point to bear in mind. And I just want to finish in the setup by showing you this. because this links very well into what Robyn does with her particular interest in female morbidity and mortality. So these are exactly the same in structure as the population graphs, but this is just looking at female deaths, high-income countries, middle-income countries, and low-income countries. And if you focus on the green, these are maternal deaths. And you can see in low-income countries, very prominent, but almost completely disappeared in high-income countries. The red are the communicable diseases. Again, they diminish as we go up into the high-income countries. But the blue is basically cancer, and we begin to die of cancer as our population ages. It isn't that people don't get cancer in these other two, middle and low. It's just as a percentage of what is killing the population, it's much lower. And the other thing, obviously, to bear in mind is to look over here, and you can see from an individual point of view, if we start here, most of the deaths for women are happening. It's young children, babies who are dying, and death across the life course at all ages. We start pushing back death when we go into the middle-income countries, and you can see that by the time we get into the high-income countries, nearly all deaths are happening in later life. And I'll talk a little bit about that in a minute. So what is the really big research and policy challenge? And I think if one wants to define it in a paragraph, or in a small sentence, it is, in the context of age structural change, the challenge in all regions is how to sustain and enhance well-being across the life course, while at the same time reducing inequalities within each generation and ensuring an equitable reallocation of resources between the generations. So for many years, people, particularly in the social sciences, have been interested in the generations, intra-generations, what happens within generations, socioeconomic differences. How can we ensure that as we have these longer lives, as we reduce our fertility, that actually we don't have inequalities within one single generation? And again, I'll talk about that again in a minute. But also, what about between generations? If we're going to give a lot of emphasis, for example, to maternal well-being in the least developed countries, what about the situation of unemployed men, for example? Or if we're going to transfer resources into older populations in advanced economies, will that take resources away from younger generations? So I think that is the way that we want to frame our research from a sort of big macro perspective of what our challenge is. So very, very quickly, I'm not going to spend a lot of time on the Institute. We actually were established in 1998 with money from the National Institute of Aging in the States. And that's actually quite significant because in the States, the NIA had set up these centers for the demography and economics of aging. And in 1998, Richard Sussman, who was then the director of the behavioural sector of NIA, gave me a grant here at Oxford to set up a UK population centre that would look at population ageing. And very, very sadly, in April of this year, at only 72, Richard died, but he transformed our understanding of population ageing. And I will talk a little bit about one of the things he was influential in later on. But you can go onto our website. As I say, in 2005, we joined the Martin School, and obviously then we're able to do far more interdisciplinary work. We also obviously receive a lot of co-funding from a variety of other bodies, obviously things like ESRC, Wellcome, Leave a Human, but also from a variety of other bodies, global as well as national. And we work globally. We have capacity built over the last 17 years, and we now have groups in Latin America, in Africa, in Asia, and in Eastern Europe, all interested in this age structural change. And we collaborate specifically with 4 centres in different parts of the region. As I say, if you go on our website, you can look much more at what we do. So what are our research questions and what are our research impact? In terms of research questions, number 1, we're interested in the impact of fertility, mortality, and migration on the age composition of populations. Number 2, we want to know how these interact, these demographic dynamics, interact with social organizations in shaping both human production and reproduction. And more recently, due to a very generous grant from the Claw Foundation, which was then matched by the Oxford Martin School, and we must thank Dame Vivian Duffield for her generosity in this, we've looked more at the role of population consumption and environment. And in terms of research impact, We have been interested in developing methodological tools. We've had education programs, we do modelling, and Institute members serve on a variety of policy units. In terms of methodological tools, we have a global ageing survey that I will talk about later. We contributed to Workability UK. We put input into both ELSA and SHARE, and more recently into the Global Ageing Index and the European Ageing Index. And in terms of modelling, and again, I'll talk more about this when we look at what we actually do, modelling longevity, modelling future fertility rates, looking at global trends and particularly intergenerational transfers and inequalities in life expectancy and healthy life expectancy. And I'll refer to all of these in a minute. So, for the second half of the talk, what I really want to do is look at age structural change, and I just want to take 3 projects that we've worked on to show how we hope we have made a difference to the research question and also to the impact question. So let's start with this one, age structural change in least developed economies, particular interest around this, which is the total fertility rate and how it is playing out, particularly in sub-Saharan Africa. If you look at this map, we've mapped the total fertility rate. That, very simply, is the number of children per woman of reproductive age. That's a very general understanding. And you can see that if you look at the yellow, the brown, and even the blue, but definitely the yellow and the brown, those are countries which are at, near, or below replacement rate. 2/3 of the world's countries actually have now reduced their total fertility rate down to near or below replacement rate, but you can still see that in sub-Saharan Africa they have high levels between about 4 and 7. So we were awarded a large grant in 2013 from the Life Sciences Research Partners to do the following: to undertake research which explores the role of education as a driver of fertility reduction, of environment, both physical, social, and cultural, as a factor in household reproductive decision-making, and the necessity of placing these at the centre of fertility reduction programs. Very much doing empirical research, but feeding into policy. And as a consequence, we've built a large network up of global associations and NGOs, communities of practice, advocacy networks, and local coordinating bodies, and in particular the first 2, which is the UNFPA, the United Nations body concerned with this, and the International Planned Parenthood Federation. We've worked very closely with the first with disseminating policy, with the second disseminating practice. So just to give you an idea of our program and some of the questions, you can see immediately, we take 2 sub-Saharan African countries here. We have Namibia and Niger. And if you look at the red, which is the total fertility rate and how it has changed between 1950 and the present, you can see it went down from 6 and dropped. It's now one of the lowest at 3.8. Niger, however, has, if anything, increased. It is still between 7 and 8. And if we put that next to a very simple graph, this is just an association, between enrolment in secondary education for women, the pink are the girls and the blue are the boys. You can see in Namibia we have nearly 70% of girls since this millennium in secondary education, compared with a tiny percentage. And I think there is a lot of evidence that actually changing education, enrolling children, enrolling particularly women in education, can have an impact on reducing childbearing in these parts of the world. Now, although we know this, many of the family planning programs do not integrate this. It is not something that they necessarily integrate as mainstream. And that was one of the things we wanted to do, produce the evidence to show that this debate between education wasn't just about empowering women, but it also would enable them to choose the number of children that they were able to have. Here's just some other very simple modelling to show you. This is in 1975, total fertility rates and average years of secondary schooling for women. And here we have 0 up to 0.4 years in secondary schooling, very high, up to 8 total fertility rates. But as schooling increased, we have over here 3.5, 2.5. You can see, so the total fertility rate started to fall. But it's obviously not as simple as that. So the other thing that we're interested in is something called the stalling of the fertility transition. What we've done here, we've modeled family sizes in selected sub-Saharan countries, and you can see that these countries are stalling, whereas these countries, which are still high, however, are in transition. What this means is that in all other parts of the world, we have seen as infant mortality falls, as economic development increases, as women's education increases, so the total fertility rate comes down. We saw this beginning in many of the sub-Saharan African countries, but then it went into a period of stall. So we focused over the last year trying to understand why are these countries beginning to reduce and then they stall. Is it something to do with, for example, desired family size, which may be higher in sub-Saharan Africa than in other parts of the world? Or is it a cultural or environmental aspect? Here we've just, this is very difficult to see, I think, but this is just to list the countries that we're particularly interested in because they've started the fertility transition and stalled, or they've not yet gone into it. So just to conclude this section, these are the research questions and output in stage 1. We have looked at the factors leading to the dropout of girls as they transition to secondary school. We've looked at the impact of some preference on reproductive decisions in Nepal, and we've looked at contraceptive use by adolescent girls in South Africa. We have a lot of papers that are available on the web. I just highlight for your interest at the bottom there. But what we're really excited about is stage 2, which we're now starting. We are entering a collaboration with the team at the University of Witwatersrand in South Africa, and we're using Agincourt in-depth data, which means that we have the DHS data, which has been supplemented by more in-depth, typically ethnographic work, to really start teasing out some of these questions. But moving on quickly, what about our work in emerging economies? Now, we are obviously interested in one of those questions I talked about, which is that how do you move a youth bulge into a demographic dividend? But I don't have time to talk about everything, so I'm actually going to talk about something which is slightly different. And it's this. If you see all these emerging economies, their total fertility rate is going down, their mortality rate across the life course is also falling, and late life mortality is beginning to fall as well. So people have become very concerned about things like the generational shift. How do we transfer generations between the resources? And what will the generational shift do to the economy at large? I just want to highlight here, this is a fantastic study by Lee and Mason called National Accounts. And just simply, just to give you some background to what I'm about to talk about, we have India and we have Germany. If you look at the dark, that's when there is actually a deficit because the young, very, very high youth population, but it's an early deficit because there are very few older people, and you can see the time of production here. Compared with Germany, where we have high levels of consumption of young people before they produce, but also high and growing levels of consumption by older adults after they've produced. And what people are saying is, can a country like India, which demographically is moving to the German demography, actually cope with the kind of economic shift that is needed? And I want to use an example of some work from our global aging study, because I think that very nicely shows some of our understanding between not only national transfers, but also transfers within households. So the Global Aging Survey, we collected data between 2005 and 2008, and my colleague George Leeson, who's the co-director of this institute, was the PI on it. We had 44,000 interviews of people aged over 40, 6,000 employers in 25 countries in all regions. And the really important thing was I talked about Richard Sussman. Richard Sussman from NIA set up a series of longitudinal studies of people over 40 and 50 called HRS. ELSA is the UK one, SHARE is the European one, and we're now beginning to get these global aging studies. And our data is comparable with them, and you'll see why that is important in a minute. But basically, we were interested in the behaviours, the health behaviours, the economic behaviours as people came up to retirement. And I just want to show you this particular finding. Looks complicated, but I'll talk you through it quite slowly. These are household financial transfers. This is generation 1, 2, and 3, grandparents, adult children, and grandchildren. Singapore, China, Taiwan, Hong Kong. These are the Chinese sample. India, Philippines, Malaysia, and South Korea. These are the non-Chinese Asian populations. One of the real fears is that as a country develops economically, so the population starts to reduce its care in terms of financial and practical support and care for its older population, and that if you grow a welfare state, the family will retract. And there's a lot of research that's been done both in our institute and elsewhere that has explored that. So you can see very, very clearly that there are actually tremendous upward transfers in these countries. The internal transfers within the Chinese households were slightly different. A lot of this was to do with residential location, because in this particular slide, we're looking at transfers where the household, within families, but not necessarily households. So a lot of these people aren't actually living together, whereas here, because the families are living together, we didn't, on this particular slide, pick it up. But you can see there are also quite considerable downward transfers from grandparents to G3. So let's just see what has happened in Europe. We then compared this with our European data. What the welfare state in Europe has done is it's wiped out the upward transfers. They've almost completely gone in Denmark, UK, France, and Germany. But we still have very strong downward transfers. This means that in Germany, in the 3-month period before the survey, nearly 40% of the grandparents made a financial transfer to a child or a grandchild. Similarly, in France, in the UK, it was about 35%. So what we're working on, and we built this into some of the work that we were doing with governments, particularly in Asia, was to say, actually, if you give income to older people, they will transfer it down through the generations. And so this particular data, in terms of input, we did a lot of work with the Singapore government using this research as they developed their Office of the Third Age and their 5-year plans. And we also built it into the Malaysian government's pension policy, which they developed in 2010. Again, here are just some papers that you may want to look at. Stage 2, we are now revisiting this data because, as I said, we now have a lot of other national surveys which are comparable with ours, and we have a book which will be coming out next year where we will be able to look at 2005 to 2015 data, and again, around these kind of questions. Not only family transfers, but obviously economic change, etc. So finally, what about the work that we are doing in our advanced economies? The really big questions that we have been looking at have been around life extension. 3 very broad questions. Number 1, will increases in life expectancy be accompanied by increases in life extension, or are we seeing a compression of longevity after 100? Number 2, the big inequality question. What about inequality in life expectancy? And number 3, will advances in life expectancy be matched by advances in healthy life expectancy? And to take you very quickly through this, because we're obviously beginning to run out of time in a minute. This is just basic OECD data looking at life expectancy. And I just want to alert you to some of the things that are important to understand. At the top, we have women. At the bottom, we have men. The men are dotted. It goes Japan, France, UK, and US. And you can see that at birth, something very interesting, that Japanese women from birth live longer, in fact, than any other women in the world. But French women are only just below them. And UK women are about 2 years below that. And what is really interesting is if you look at the data from 1945, French women have been 2 years ahead of us since 1945. We've gone up, but we have not closed the gap. Maybe in questions, I will tell you why I think it is. I haven't really got time now. But really importantly, if we move on to age 65, some really interesting things happen. The gap actually begins to get better. This is life expectancy. Let's look at women at age 65. And you can see the French even start to overtake the Japanese. And when we look at life expectancy at age 80, French women actually at age 80 have a longer life expectancy than Japanese women. So this links into this question, which my colleague George Leeson, under the Oxford Martin Demographic Modelling Project, which we started about 2-3 years ago. Will increases in life expectancy be accompanied by increases in life extension? It's all about the compression of longevity. Here's some modelling looking at the number of centenarians in England and Wales. We currently have about 14,000, I think. In this one, we're looking at 1922 to 2012, and you can see, if we just look at the red of females, look how the number of centenarians took off round about the early 60s, men less so. These are the projections that George has done, looking at 2010 to 21. You can see men and women, late life mortality is closing for men and women, but look at the numbers that we are expecting. Here we have, I think it's, let's take 2080. In total, we will have about 1 million centenarians in this country. Currently, about 8 million people currently alive will make it to 100. And the projections say that half of the babies that are currently being born in this country have a life expectancy, half the babies being born in this country will make it to about 103, 104. In Japan, it's about 107. So the centenarian is here to stay. This has some very interesting things about death, and I'll just very quickly talk to you about this. This is what is happening to deaths, and again, it's work that George has been looking at. And if you look here, let's look at the blue. The blue is total. The red is deaths over 60. The green is deaths over 80. And the dark blue is deaths over 100. And that's going up to the middle of the century. We are currently around about here. And you can see that we're pushing deaths further and further back. What is very interesting is here, if you look at the total, round about now, we seem to have a reduction in deaths. And that's probably for two reasons. One is to do with the size of birth cohorts coming into very late life, but also it's because we're pushing death back. So as we have more 80-year-olds dying, so we see a decrease coming in here. And the big question, are we seeing a compression of longevity under 100? Sadly, the UK statistics are not sufficiently robust to answer that. So George is now working with the Danish Statistical Office that have linked register data to try and see. There's a demographer called Fries who believed that we were actually always going to have a narrowing of our bell curve. In other words, more and more people would sort of dash up to 120 and nothing would happen. But the evidence from Japan is no, actually, as we get more centenarians, we also get more super centenarians. What about the relationship between life expectancy and healthy life expectancy? I won't go into that in detail just because of time, but what I think we're seeing is that we're pushing back the onset of frailty, but maintaining that state for longer. In other words, it's a good news, because if we're actually going to have more and more people in their 50s, 60s, and 70s who are fit and healthy, we can actually work longer, which is what government wants us to do. But if when we get into frailty in our 80s, we're staying frail for longer, that is a bad news from a point of view of resources and healthcare, and maybe something that Robyn will touch upon. So again, just to show you very quickly, this is EU data, and the dark lines compare life expectancy at 85, and the dotted lines compare healthy life expectancy, and you can see for all countries that growing gap between life expectancy and healthy life expectancy. And again, maybe in the questions we can talk a bit more about that. I want to finish this just by showing you this graph, because I showed this graph in 2012, and since then we've had some really interesting evidence that I just want to share with you. This is UK male mortality, and it's mapped from ONS data. It's the causes of deaths, and very quickly you can see, if you look at the red, infections, First World War, Second World War, but then flattened. Very few people die from infections. The same with the green, which is pneumonia and other respiratory. Lots of people died in the Spanish flu epidemic, huge peak. Very few people now die from these kind of diseases. Cancer, very interesting, and again, I think Robyn will talk a little bit about this. More people are getting cancer, but we're living with it for longer. And this is the really interesting story that I spoke about, those of you who heard me in 2012 talk about this. This was cardiovascular disease, and this is the smoking epidemic. Men stopped smoking in the 80s, dramatic fall that actually came through on the mortality figures. So what I asked was, what is going to happen now as we go into the 21st century? Because the new epidemic isn't smoking, it's probably obesity. And just a really interesting paper that's just come out, or it came out before, but I have only just discovered it. And this is looking at the impact of life behaviour on life expectancy and disabled-free life expectancy. And interestingly, it shows that whereas smoking reduces both life expectancy, but also increases disabled years, so does alcohol. Obesity doesn't seem to reduce our life expectancy, but dramatically increases our disabled years. Now, I'm going to skip, because I know I've got to, Julian, I think, come to a halt. Yep. So I'm just going to finish with looking at this. This is looking at inequality in mortality, and maybe in the questions we can talk a little bit more about it. And this is some work that we did on differential longevity in the UK with 2 million pension records, and it answers that final question about inequality. This is comparison of UK life expectancies from age 65. Not to go into too much detail at this stage, but basically we had a low-income ill health group and a high income, and there was an 11 years difference at age 65, depending which group you were in. It obviously mirrored things like the Whitehall study, but because it was such a large sample, we could start messing around with the data a bit. And when you look at 85, a 50% chance when you reach 85, a 50% difference in the probability of reaching age X at 85. So the older you get, the more those inequalities come through. I think this is particularly interesting because it comes back to the story I started a few minutes ago. What we then were able to do was to differentiate between the different factors. This is our poor group, poor, unhealthy, ill health retiree. If they'd done a manual job, they would have added 0.7 on. If they'd retired in normal health, 1.8. If they'd had an income, 4, but overwhelmingly a healthy lifestyle, 4.6 years. So healthy lifestyle is really important. Healthy lifestyle is important in the healthy life expectancy story because particularly things like obesity are increasing our time in disability. It's also important here in increasing our longevity. And finally, very interesting study that we've just looked at is the regional effects on mortality. These are the most affluent across different regions. And the important thing is, in an affluent region, regardless of whether you are poor or rich, it doesn't really make that much difference with your life expectancy. But in a deprived region, it makes a huge difference, which is why the variance is so great in this second slide. And we're now working to try and understand what are the geographical dynamics. Is it that if you are rich, you can buy your way into decent healthcare? Or if it is that you're rich, you actually don't associate with maybe the poor group that you are living with? But we have, I think for the first time with these numbers, shown very clearly the local effects on differences in health, in life expectancy, and actually also in health equality. And this just shows how we fed into these two, the government review and the health of the population. And I'm actually going to stop there. Thank you.
Good afternoon. Now let me first figure out how to work the technology. So I need to change the presentation. Thank you, Carolyn. And just as we're setting up my presentation, again, as with Sarah, just like to acknowledge the support that we've received from the Oxford Martin School. We're a relatively younger organisation in terms of our relationship with the Oxford Martin School compared to the Oxford Institute of Ageing. But as an organisation, we've been in existence pretty much the same time as the Oxford Institute of Ageing. What I'm going to talk about today is firstly identify 3 key challenges that I believe are important that have emerged out of demographic change. I'm then going to talk a little bit about how the George Institute for Global Health has addressed those challenges over the last few years. And then I'm going to talk about what the George Institute for Global Health is going to do over the next 5 years, hopefully, and what we will produce. So starting off looking at the key challenges that we face, and Sarah's already started to allude, wrong one. Right, well, this is the button here, is it? No. Aha, right. The first challenge that clearly we see is really important emerging from the demographic change is the changes in the burden of disease that have occurred over the last 50 years, essentially, at a global level. And even over the last 10 years, what we have seen is a decrease in the numbers of deaths from communicable disease, maternal disorders, and nutritional conditions, and an increase, particularly in the numbers of deaths from non-communicable disease. This is a challenge globally, but particularly a challenge for low and middle income countries, because it requires that they have to change their health systems from dealing with acute episodes of infectious disease to dealing with populations who have chronic disease who require long-term care. Particularly what we're seeing in terms of the 10 leading causes of death in the world, we see the emergence of cardiovascular disease in particular. As you'll see, the leading 2 causes of death in the world are ischemic heart disease and stroke. But of the 10 leading causes of death, 6 of those are non-communicable diseases. We add in road traffic injuries, 7 of the leading causes of death are now non-communicable diseases. So health systems have to change and have to respond to be able to cope with this changing burden. Importantly, what we see is most of the world's population are described as middle income. And this is where we're seeing the greatest impact of non-communicable disease. Because arguably in high-income countries, we've had many years to adapt to the changing demographic, the changing global patterns of disease, and health systems have been set up to manage chronic disease. But in low and middle income countries, and indeed low income countries, they're still trying to cope with providing health care for individuals to deal with infectious diseases. Now they have the so-called double burden to try to cope with dealing also with non-communicable diseases. So that is our first challenge that we see. The second challenge, though, is something that affects high-income countries and low and middle-income countries alike. Globally, we're seeing dramatic increases in the cost of healthcare. In part, more populations, ageing populations, but in part, the change in the global burden of disease, the pattern of disease that requires people to use healthcare services for many times over their lifetime. These changes in the healthcare costs are particularly particularly related to treatment. The changes in the increases in costs are not related to preventive care, but it's the increase in costs associated with the treatment of those conditions. And the costs in particular that we're talking about here are increases in high-cost hospitals, in the costs associated with staff, and particularly physicians and specialists, and also the costs associated with new technologies. All of these contribute to the costs. So in high-income countries, we've reached a point, particularly, say, the US, where now about 18% to 19% of gross domestic product is spent on healthcare. This is just not sustainable in high-income countries. In low-income countries, the percentage of gross domestic product is about 5%, so considerably less, potentially room to spend more, but those countries have got many other issues that they have to deal with as well. So it is as much of a challenge for high-income countries to manage cost as it is for low-income countries to increase their costs. The third challenge that relates to this is the issue of the healthcare workforce. High-income countries have about 27, if you look, back again. High-income countries, if you're looking at the US, at the UK, about 30 physicians per 10,000 population. The US, about 27 physicians per 100,000 population, compared to the levels in sub-Saharan Africa and parts of Asia. Very vast differences in the numbers of physicians. And if we go into specialists, for example, the numbers of psychiatrists, the difference between what's available in high-income countries and low-income countries is even greater. So a real challenge is that many people in low and middle-income countries, particularly in middle-income countries, aspire to have the same healthcare systems that we have in high-income countries. And governments attempt to try to move to the same sorts of health systems, but they can't. It really is impossible to do that in sufficient time to satisfy the needs that people are going to have over the next few years. So we have a real challenge here. In countries like India, we just can't scale up to the level of high-income countries. So what this means is we need a very different model of providing healthcare across the world if we're going to meet the demands of the changing demographics and if we're going to meet the demands associated with the changing disease pattern. So how do we respond to those three challenges? Well, fundamentally, we need a combination of research that is about discovery, research into what are new causes, new preventive strategies, and new low-cost treatments to manage those diseases. But we also need to have implementation research, research to help get evidence into policy and practice and to improve healthcare. And this is essentially why the George Institute was established. The George Institute was established in 1999 as a not-for-profit medical research institute. Our mission was to improve the health of millions of people worldwide. I think we keep saying we should change that to improving the health of billions of people worldwide. We should be far more ambitious. We started off with our centre in Australia, which remains our headquarters, and then moved to establish centres in both China and India, and 5 years ago moved to establish the George Institute also in the UK. In each of those centres, we're affiliated with leading research-focused universities, and of course, in the UK, we're affiliated with the University of Oxford. So we were established 5 years ago with start-up funding from the Oxford Martin School, matched by start-up funding from the George Institute out of Sydney. We now have a team of about 30 individuals here. We have 4 programs of research that we're engaged in Oxford: healthcare innovation and evaluation, children and adolescents, big data and healthcare, and our Oxford-India collaborations. Both globally and in the UK, our approach is to conduct large-scale population, clinical, and health systems research, and our focus is innovative, scalable healthcare solutions. Our particular focus is on the common causes of death and disability, as I outlined to you earlier, particularly non-communicable diseases and injuries. Our focus is how do we provide healthcare solutions that are accessible to disadvantaged and vulnerable populations in resource-poor settings in high-income countries. So, for example, we work with Aboriginal and Torres Strait Island populations in Australia, but also disadvantaged and vulnerable populations in both China and India. And that means less focusing on the cities, but more focusing on rural populations. And the third focus of our research is really to identify low-cost, innovative, technology-driven solutions to address these challenges. So what I'm going to do in the remaining part of the presentation is to describe some of our examples of some of the work that we've done over the last 10 to 15 years, which will give you a sense of how we operate and how we've succeeded, I believe, in the sorts of things we've set out to do. And then move from there to focus on what you might expect to see coming out of the George Institute over the next 5 years. I'm going to use some examples of our discovery research as well as some examples of our implementation research. So if I move firstly to our discovery research, and here we're talking about a study that Mark Woodward, who's Professor of Statistics and Epidemiology, both in Sydney and also here in the UK, has been one of the leaders of a very large-scale collaboration, the Asia-Pacific Cohort Studies collaboration, which has involved groups from all around the world, numbers of participants followed over many years, and essentially what that group have done over time is established associations between major risk factors and a range of non-communicable disease, particularly in Asian populations, because most of the research before has focused on high-income populations. So this research is unique, and it's enabled us to identify whether many of the associations we had seen in high-income countries can also be seen in low-income countries. So over the course of the 15 years that this collaboration has been in existence, we've had over 65 publications in many of the world's leading medical journals. We've also focused on looking at new preventive strategies. And one of the things that we've been involved in doing is establishing Food Switch, a consumer tool which enables consumers to download an app on their phone to go into a supermarket or some other setting, similar setting, to identify the composition of foods, and then to identify whether there is another food on the shelf, another product on the shelf that has less salt, less fat, or gluten-free, or whatever individuals might require. This product was downloaded, launched first in Australia, then New Zealand. It's been launched in the UK, and last year won Public Health England award for that product. It's about to be, it was just launched in South Africa end of last year, and is about to be launched in India as well. And we're collecting a massive database on what are food products that are out there at the moment, which we hope we'll be able to use as well. The third focus that I want to outline to you is we're also looking at new treatments. And here, this is a major study involving almost 3,000 patients from 144 hospitals, 21 countries. Again, you'll see low and middle income countries included in this study. And basically, this study was a focus on stroke and showed that rapid intensive blood pressure lowering improved functional recovery after intracranial hemorrhage. So that gives you a sort of sample of our research that looks at causes, our research that looks at new prevention strategies, research that looks at new treatment strategies, but then we're also involved in implementation research. And here is an example from China where we've been looking at clinical pathways for the management of acute coronary syndromes, where we've focused on hospital care and looked at what's happening in hospitals, started off with an observational study, 51 hospitals, mostly on the east coast of China, looking at how they managed patients with acute coronary syndromes and compared them with Chinese and international guidelines. Not surprisingly, a significant evidence practice gap in what was happening. So the next phase of this study involved a cluster randomised controlled trial, 75 hospitals, starting to move further west and engage a greater number of hospitals to try and look at how to change practice to reduce those evidence practice gaps. We didn't have such great success with that research. We learned a lot of lessons out of that. And one of the biggest lessons we learned is we hadn't taken into consideration sufficiently the financial incentives for doctors in terms of how they perform. So we learned from that, and we're just finishing phase 3 in 25,000 patients from over 100 hospitals, where we've gone further west into, I'd hardly describe them rural parts of China, because many of the centres there still have cities of 10 million, but further west, away from Beijing. And learned lessons from that second phase and are just analysing the data at the moment from that. And certainly we hope as a result of this, through the process of this research, we will have changed clinical practice in the management of acute coronary syndromes. A second focus of our implementation research is to move out of hospitals into communities and really focusing on primary care. And this is where our particular interest in looking at how can we set up treatment systems that don't have to rely on a doctor. How can we set up treatment systems that also can utilise technology? And this is the approach that we've taken, that we have looked at training non-physician healthcare workers, giving them electronic decision support, algorithms of care, and using low-cost PC tablets so that they can follow a process to systematically appraise, refer and treat individuals at high risk of cardiovascular disease. Now, we have been able to we started off doing this in Australia, particularly in rural and remote parts of Australia, where we've integrated GP, pharmacists and patient decision support combined with polypill and pharmacy interventions for cardiovascular risk management, shown very positive results out of that research. We then moved to India, working in rural villages in Andhra Pradesh, where again we've used decision support for community health worker-led management of cardiovascular disease and also common mental disorders. And that study is ongoing at the moment, led by Pallab Malak, who's our Deputy Director, who's also here today. And that study is ongoing at the moment. The first phase of that study showed quite clearly that non-physician healthcare workers were able to identify people at high risk of disease at least as good as physicians, and they were able to refer even better than physicians were able to refer. So really promising first stage findings from that, and we've now moved the study into the integration with the technology focus. We've also used this approach in 5 provinces in China, in rural parts of China, again using decision support for doctors and family healthcare promoters, particularly for diabetes care. And now this is the point where I move into where we go from here, what we've done over the past to what we hope we'll achieve out of the George Institute in the UK over the next few years. The next phase of this piece of work, Smart Health, called Support CVD, Support Cardiovascular Disease, is focused in Iran and is led by Professor Kazim Rahimi. He's the Deputy Director of the George Institute here. He's on clinical duties today, so he can't be here. So if any of his team think I'm not representing him properly, they can make a comment later. So basically what Kazim has been doing is working in Iran with about 60 villages in rural parts of the country, again using the same sort of model, using non-physician healthcare workers, using technology to better identify and manage individuals at high risk of cardiovascular disease. So as I said, I'm moving now to focus on what we hope will be some key findings coming out of the George over the next 5 years. A second piece of implementation research that we're engaged with here, and that Kazim in particular also is taking the lead on, is a project called Smart support heart failure, support HF. And this is a really, in the UK, as I showed at the outset, increasing hospital costs. Ideally, if we can keep people out of hospital and manage them out of hospital while maintaining quality care, we have the potential to make a dramatic difference in this country. So basically, this is a study which is supporting UK patients with heart failure once they come out of hospital to manage their health better at home through technology. Their technology feeds back into their GPs, so the GPs are aware when people are, as they monitor their health, when they start to see signs that suggest they should go back into the hospital, then they can do that. So hopefully the results of this will be forthcoming in the next few years. If I move now to provide a couple of examples of some of the work that we're doing on what are causes and really change the focus. And this is some work led by Professor Terry Dwyer, who's the executive director here. And the focus here is really going back to children, because arguably the disease process starts in childhood, and if we can start to intervene at a younger age, then maybe we can stop the progression of cardiovascular and other disease at older ages. What Terry has been involved in setting up over the last 40 years, well, you haven't been setting it up over 40 years, but essentially Terry leads a cohort studies collaboration which recruited 40,000 children at birth. They've now been followed up for 40 years, 7 cohorts across Australia, Finland and the United States. And they've already had some preliminary results out of this work, which is starting to address issues of what happens here when these are individuals who, if I get this right again, in adulthood are normal weight. And it doesn't really matter whether as children they were obese or they were normal as children. Basically, it really, in adulthood, if you're a normal weight, you have less chance of getting elevated risk factors for cardiovascular disease. However, if as an adult you're overweight and obese, it doesn't really matter if you were obese when you were a kid or normal when you were a kid. So really important information that's starting to come out of this study, but the real results from the study are going to come out over the next few years. Moving from children to women. Sex matters to the heart, and this is work that's led by Mark Woodward and Sonna Peters. Basically, mostly people have thought of cardiovascular disease as a men's disease. Most of the research has been done on men. We've known very little about what are the risks of cardiovascular disease. So fundamentally, what Mark and Sonna have been doing, have been starting to look at what do we know when we start to look at women, what do we know, what are the differences between men and women? We know that women start to get their first cardiovascular disease later in life, presentation is different, and we know that certain risk factors are more strongly associated with cardiovascular disease in women than men. Why? We don't know. So just to give you a quick example of that last one, some of the work that Sonna has led here is showing that if you look at individuals with diabetes, men and women, basically we see that women have a 44% greater chance of getting heart disease if they've got diabetes compared to men. Women have a 27% greater chance of getting stroke compared to men if they have diabetes. So really the next phase of research that Mark and Sonna will be engaged in is trying to understand, get better estimates of these sorts of differences, try to understand, is it biological factors that are important, or is it health system factors that are important? Do women and men access healthcare differently? So that, I hope, provides an overview of the sorts of research we're doing, and I really want to finish with the last slide, which does show that we do the research and we also want to make sure those ideas move into action. As Julian indicated at the start, we have an interest in women. I've got a particular interest in women, but I think half the people in the audience probably have as well. And we were fortunate in getting support from the Oxford Martin School to take our thoughts on this into the development of a policy paper. Basically, as I just indicated, we believe the agenda on women's health, frankly, needs to move from an almost sole focus on sexual and reproductive health to what are the leading causes of death for women and adolescent girls, and the leading causes of death and non-communicable diseases and injuries. We also need to do, as Mark and Sonna are doing, much more research that takes a sex and gender-specific analysis approach so that we can better understand, are there differences? And then we need to invest resources to reduce those disparities. We hope to launch policy papers in the Houses of Parliament in February next year. We're starting a policy dialogue with key government players in China next month. We'll do much the same in India and then also in China. So time's up, Julian. Thank you very much.
Okay, thank you very much to both our speakers. We do have time for questions, as I said, so there is also a roving mic, so if you could indicate your interest in a question, and then a mic will come to you. You should be warned that this is being webcast, so if you don't want to be filmed, don't ask a question, okay? So, please.
Question to both of you. Very little mention mental health. And mental health is a huge area of health concern all over the world. 1 in 4 maybe, and also resources which are much lower in mental health. Could you tell us perhaps, are you looking into this, and if not,
Well, I mentioned the smart health work that we're doing, which is using non-physician healthcare workers and technology with some of the work that we're doing in India. Part of the work that Palab has been doing, firstly, is looking at reducing the stigma associated with mental illness, and then going into multiple villages in rural parts of Andhra Pradesh, including into some of the scheduled tribe areas, to really start to better be able to identify individuals who are at high risk of common mental disorders. And one of the beauties we believe about technology is it should minimise stigma that might be associated with people asking questions. If you've got a standardised format, if you've got a technology-driven format, it should allow you to do that better. I think the last thing I mentioned, just with the women's health stuff, when I talked about we need to move NCDs and injuries into the women's health agenda, I mentioned particularly adolescent girls. We know self-harm is one of the leading causes of deaths for adolescent girls. It needs to be on the women's health agenda, so we very much see that so important.
And yes, I mean, one of the areas that I wasn't able to cover at all, and deliberately didn't, was the work that we do on health, and particularly Kate Hamblin, who is one of our senior research fellows, who has done a lot of work looking at health and technology, and also particularly in her particular case, dementia. And one of the slides I had to whiz through was actually some very interesting research which is showing that the prevalence of dementia in the UK, this is a very, very large cohort study that actually was led by Cambridge, published in The Lancet a couple of months ago, that the prevalence of dementia in UK looks to be going down. And that's really, really good news. Why that is happening, is it a cohort effect? Is it drugs? Is it education? Is it that we're just delaying? But yes, the whole area of health and dementia is something that we have an interest in.
There's another question here.
Thank you. Hello, I'm Sushant. I'm from India. And the question I have is around, so you mentioned the role of primary healthcare, and especially empowering the frontline workers and enabling them to provide a lot of the healthcare services. So, but in my experience, what I've seen, so there are a lot of guidelines which are, let's say, coming around from WHO or from other multilateral organizations, and especially around maternal health. I remember seeing one of the guidelines which talked about moving more towards tertiary care, where they said that if you really want to prevent the deaths, then especially for MMR, then deaths can really be prevented at tertiary care. So the recommendation was to have at least 50% of services being provided at tertiary care, 40% at secondary, and 10% at primary. So in your experience, do you also see a move towards more and more tertiary care rather than primary, rather than focusing on secondary and primary care?
I guess I'll respond to that in a couple of ways. I think, as I mentioned, with a growing middle class in many countries, people's expectations are that the healthcare provided in hospitals is going to be better, of higher quality than healthcare provided in primary care. But unless we can provide the evidence to show that we can provide healthcare in a primary care setting that is at least as good as that being provided in hospital care, you won't see that change. We do need to move people out of hospitals into the primary care setting, but no one's going to do that if they think they're getting second-class care. So that's why we need to do the sort of research that we do to show that using the sorts of algorithms that we have, high-risk people will go to hospitals, will be sent to hospitals because that's where they can get the best care. But for many of the other people who don't need to be there, they can be treated effectively in the primary care setting.
Okay, we have a question here.
I was really interested to hear what you were saying about Africa being the kind of area of the world with the predicted, with the highest rate of birth by 2050. I was wondering whether you thought this would take hold in some states much more markedly than others, and if so, what do you predict will happen to the development gap both within the continent and within the countries as well?
So that, I mean, really that's the sort of key question, because a lot of what we looked at the moment was very much sort of mapping at the national level, and it became clear that we really had to go down much more to the local level. I think a really, really big question that we haven't resolved is the following. There is this presumption at the UN when they are modelling maximum world population is that the total fertility rate of every country is going to be round about replacement. So that's round about 2.1. So the presumption is that most women want 2 children, a boy and a girl. And survey research typically shows that out, that actually desired family size and actual family size, that there has been a convergence in Europe and in many other parts of the world. There is some suggestion that actually in some parts of sub-Saharan Africa, desired family size is not 2, it's probably nearer to 3 or 4. And there is quite a lot of evidence now coming out from some research that when you have highly educated women who are in the workplace, and therefore one presumes they would have dramatically altered their childbearing rate, they actually, both in the number of children they're having and in their expressed desired size, are coming down to about 4. Now, if African women want to have 4 children, then that will fundamentally change the whole population profile of the world. And at the moment, you know, it's really unclear, but it's also unclear that the role of culture, the role of religion, the role of family. You know, we have some interesting research that's coming out of Ethiopia, which is looking at whether family systems are such that the woman lives with her mother or with her mother-in-law, and that evidence suggests in this particular study that if you live with your mother-in-law, the mother-in-law wants you to have more children because she wants her son to have lots of children, so pressure is put on. So when you're making that kind of decision, no matter how empowered the woman is, she's obviously in a family context that encourages childbearing. If she's living with her own mother in the same society, but her mother is the one that she is residing with, then in fact she will have fewer children because the mother is more concerned about her welfare. So there's lots of dynamics that we really don't understand. But yes, I think you're right. That's why this in-depth work is so important, because it's ethnographic, local collection of material, and it can really start teasing out some of these sort of household decisions.
We had a question here, Jake.
Thanks. We've seen that there's a huge growth in non-communicable diseases, especially those diseases related to obesity, such as diabetes in Asia. A lot of that to do with inactivity. But much of the debate around health seems to be in the media. And the media tends to take a sensationalist approach, and I feel there's a real lack of holistic thinking about many issues. So just for example, in the last UK elections, it was a competition as to who could spend the most on the NHS, and there's a £5 billion hole in the NHS budget. But there was no discussion about actually if people walked and cycled the shortest distance to school and to work, the estimated saving to the NHS is £6 billion. And so as you get these developing economies where they aspire to, the Western lifestyle, they start to drive more, that there is a continuance of that growth in obesity and all those associated diseases because they're following, the Western lifestyle. But my real issue is, so there is a real lack of connected policy making to connect health and transportation and air quality and mobility and being active. So how can we get into the public debate a better discussion about preventing disease rather than just curing disease?
Look, all of what you've said I totally agree with, and as I mentioned when I showed that cost slide, if you then superimpose or underimpose almost the costs on prevention, they're sort of tiny compared to that. And so you're absolutely right, prevention is really going to be a major focus of how we bring about change here. But you have raised the issue of what is the responsibility of those of us who are researchers to get more and more involved in the policy debate. And I guess that's part of the thing about being part of the Oxford Martin School, that we're here trying to continue to do great research, but also trying to put those agendas into the policy arena and take a much more responsible role. But of course, reality is always about, we've still got to get the funding to do the research to be able to say these sorts of things, and trying to encourage researchers to get up and be counted in the policy debate is still a challenge. But again, I think that's one of the reasons why we're here at the Martin School. Forums like this, opportunities to produce policy papers. I mean, the part of the reason we put up to do the policy paper was fundamentally arose out of issues like, most recently, there's been a new global strategy for women, children and adolescents' health. That strategy almost entirely focuses on maternal and reproductive health. They should have called it the Global Strategy for Maternal Children and Adolescents, because there's very little there about non-communicable diseases, mental illness at all. And I think that's why it's sort of like, well, why isn't it? It's because we're not getting up there and saying enough about. So that's what we're here to do.
There's another one over there.
Going in the same direction as well. I have two questions precisely. One is related to what Sarah Harper said about you have a decline in the fertility rate in many countries, and advanced countries particularly. A lot of people say that maybe immigration could be the solution. So my question is, do you think that is one of the solutions to become younger, I would say, in advanced economies, or do we can say that we should decline the population of advanced economies and that's it? So that's one question. The second question is related to the distribution of density, physician per density population. And what I like in the graph is that you said that in Africa, for example, you have one doctors over 10,000 population. If you correlate that with the fact that in these countries you have a lot of immigration of doctors particularly, and as we can see in many medias, you have a statement that said there's much more Malawian doctors in Manchester than in Malawi. What can we do maybe to avoid these people to immigrate and to cure maybe much more people in sub-Saharan Africa?
I mean, I think in a way you've actually captured both really key ends of the argument. You've talked about what happens in the receiving countries and what happens in the pushing countries. So from the receiving country point of view, the evidence, I think, is quite clear that migrants are typically good for European and North American, etc. economies. There is very little evidence that they're actually a drain on welfare. And furthermore, there is very little evidence that they take jobs away from local people. So that is the evidence, and it is clear. One way of looking at it is that at the national level, migrants are good. However, without any doubt at all, politicians fear what happens at the local level, and that is when you can get local conflict, because people perceive that schools and health services and jobs and houses are being threatened by people coming into their area. So politicians at one level are stepping back, but we have all used migrants in advanced economies over the last 50 years to compensate for the ageing of our populations. And one can say that one of the reasons why Germany over the last 6 weeks was very keen actually to take the large numbers of so-called refugees, because some were, some weren't, but large numbers of them were skilled because they had the resources actually to be able to come to Europe, was because Germany's population is declining dramatically. Germany will go from down to about 60 million by about 2030. We will increase to about 80 million because migrants also increase your total fertility rate. And so Germany actually needs the skills of migrants. Then, of course, you come to the other problem, which links exactly into what Robyn was talking about, is that exactly that's the problem, that to a certain extent we have cherry-picked the skills from developing and emerging economies. And should we do that? Can we continue to do that? And how can individuals who probably have every right to be able to move if they have the skills and resources to do so, how can they be encouraged to stay within their own country, which is where Robyn sort of comes in on this.
I think all I would say is that the George Institute wants to show by example. So the very reason why we established the George Institute in both China and India, and the very reason why almost entirely our staff in China are Chinese, almost entirely our staff in India are Indian, is because we want to grow capacity. Palab, for example, was trained here in the UK, then trained in the US, came back to India, and I know for a while he fluttered and thought he might want to come back, but we have created an environment that he wants to stay there. He realized, I think we all know that we want to improve the environment for people there, which means for professionals they've got to have the environment where they can be encouraged to stay and grow. But Palab comes here and interacts with our staff in both in the UK and in Australia, but is back committed to working within the country. And I think that's the way in which we are trying to address this issue, because that break, having said that, we still have a number of our staff who choose to come and work with us and don't want to go back, or work from a base in Sydney or the UK back in their countries. Exactly what Kazim's doing with the work that he's doing in Iran at the moment. Basically, he's working with partners there to create environments where they're doing world-leading research so that colleagues in Iran will choose to stay in there and recognise they can do the sorts of things they might want to do by coming here. So it's not a full answer, but I guess we're trying to show by example.
Okay, thank you. I'm just looking at the clock. I think we will close there. I just do want to draw your attention to a couple of other events before we give a final thank you to our speakers. I said at the beginning that this was a celebration in the sense of the whole seminar series. Normally we pick a topic and come at it every week from a different angle. This term, what we're doing is dotting all around the various subjects and highlights of the very varied research programs of the school. And so do look at the website. But just to give you an idea, for next week at the same time, we have a talk on Can Solar Energy Tackle Climate Change? And we have Professor Henry Snaith, who is one of the directors of our program on solar energy, who's developed an alternative to silicon. And we have Professor Malcolm McCulloch, who is running a new Oxford Martin program on integrating renewable energy, so looking at some of the challenges. If you have good solar, how do you get it to work? And then the following Thursday, again at the same time, we have Professor Nick Bostrom, who is the author of the extremely successful book Superintelligence, which you may have seen in bookshops around Oxford, about AI being much in the press recently, warning about some of the dangers of the power of AI in the future. And he will be talking on the future of humanity. So he probably won't need the full hour, but do come along. It will be a packed talk, I'm sure. And it's not just the seminar series, so just to draw your attention to some of the other events, I'll just mention two that are both quite high-profile speakers at the Sheldonian. On Monday, we have Lord Stern, who is one of the sort of big thinkers on climate change globally, who will be talking with the title, Why Are We Waiting? The Logic, Urgency and Promise of Tackling Climate Change. So he's the president of the British Academy and a famous economist, and so will be, that talk will be, we think, heavily oversubscribed. So go to our website and register if you're interested. And just the last thing to draw your attention to, on the 23rd of November, again at the Sheldonian, we have Lord Martin Rees, who's the Astronomer Royal, and that will be the 10th anniversary lecture of the school. And he will be talking on, will technology's dark side eclipse humanity's bright future? So he's an optimist, but he knows the dangers. So on that, I'd just like to conclude with a final round of applause to thank our speakers for tonight. Thank you.